So hi everyone, I'm Celia Lar. I'm a researcher at Women's College Hospital. I'm focusing on implementation science, and with Childbright, I came involved for phase 2, and I'm co-leading the training and capacity building group along with Dan and Pierre. And it's my pleasure to introduce Dr. Noah Ivers today, who's going to be presenting a whirlwind tour of implementation science and kind of why that matters with a bit more of a research focus to some of this, but some really interesting examples of how we can use this work. And I've had the pleasure of working with Noah for the last several years, and a lot of what I know about implementation science has all come from him. So Dr. Ivers is a family physician at Women's College Hospital and the University of Toronto. He holds a Canada Research Chair in Implementation of Evidence-Based Practice, and Noah and his team focuses on the use of data to drive evidence-based, patient-centered improvements in healthcare. So we'll pass over to Noah for his presentation.
Awesome. Thank you, Celia, and thank you all for being here. There's a lot of folks here, and that's really wonderful. I hope I can keep your attention. That's my goal, at least, for the next 20 to 30 minutes. I, at the very least, have some slides that ought to keep your attention, even if what I have to say doesn't interest you all that much, but I hope it will. As Celia mentioned, I'm a family doc, and so that is the first caveat that I'll just offer before I launch in. It biases sort of how I see challenges in implementation, for better and for worse. You know, not only is my sort of perspective biased by, you know, being a doctor in general, as opposed to, you know, some other kind of perspective, but also, you know, from my perspective in primary care, I see things perhaps differently than some of you. So take that as you may. What I'd like to do is sort of cover a lot of ground, but give you a bit of a framework for how maybe you might think about implementation science and how you might think after leaving this next 20 minutes with that we share together at 30, that it might actually be somewhat useful for you. So we'll see if I hit that goal. So before we dive deep, one more sort of prelude, I guess, is, you know, this is the way I think we used to think about putting best practices into routine care. On the left, you see this very simple, linear sort of process of new evidence, new research being done. Then somebody can put it into a guideline, and then, of course, that would lead to better care. And I have this this sort of stylized picture, Charlton Heston as Moses here, basically to point out that guidelines don't self-implement, and they don't sustainably implement either. If that were the case, then we would all be following the 10 Commandments. So we need some more systematic approach to putting new evidence into practice. The other sort of background information that's useful to reflect upon is that when you start to open the curtain on the healthcare system, you realize that it's not maybe what you would have hoped. And I think I'm preaching to the converted here. Everybody knows that for folks living with complex illnesses, the healthcare system isn't doing all that we would have hoped. And even when it tries to, it doesn't necessarily implement those things reliably for all sorts of reasons. And more broadly in the healthcare system, you know, we know from decades and decades of health services research that both overuse and underuse, as well as misuse of different healthcare services or prescriptions or diagnostics, that's the norm. So, you know, it's normal to find that when you peel back the curtain, things are not as you would have hoped. That's a picture from The Wizard of Oz for those that are not familiar. Okay, so where does implementation science fit in with all that? Well, I think it's fair to say on the one hand that it's a novel field. that sort of incorporates a broad range of disciplines and disciplinary approaches. I'm going to talk to you today mainly about one perspective of how you can think about implementation science, try to make it sort of something you can really chew on without diving deep into all the literature. But in fact, it's quite complex because it seeks to solve problems that are complex. And so you see this famous picture, this famous comic on the right of your screen there, that, you know, we tend to be attracted to simple linear solutions. But in fact, the right way forward usually recognizes that the challenge in front of us is a little more complicated than that. Typically, implementation science tries to unpack that more complicated path forward and, you know, tries to show a way that might be, you know, more successful. So this is a slide developed a few years ago, not by me, but I find it incredibly helpful because it takes the sort of complicated language out of it. So when we talk about implementation science, this helps, you know, I think many people make sense of what it is that I'm trying to talk about. So as opposed to clinical research, which tries to unpack whether something makes clinical outcomes better, you know, if we already know that something is a best practice, that's the thing. If that best practice is an intervention or an innovation or some way of doing things in the clinical world or in or at home, for instance, for children with complex illness, that's the thing that we want to see happen. We could do usual effectiveness research to make sure that that thing works, perhaps in a new context, or perhaps that it works better than some other thing. The goal of implementation research is to make sure that that thing gets done reliably. So how can I know whether people are reliably implementing the thing, and how can I get them to do that thing better? So there are implementation strategies that we can go and apply to get people to do the thing better. And then we can use implementation outcomes to assess how much or how often or how well they implemented that thing. So that's the place where implementation research lives. It lives in the world after we know what it is a best practice or not. I hope that makes some sense. It'll come more alive as we go forward. So others have defined implementation science, and as it's a new field, you can see that the definitions aren't all the same, which is a bit off-putting. I think once you leave these 30 minutes, you'll have a sense of what it is, though, because there's actually really good overlap here. And, you know, I like to look at what the Implementation Science Journal talks about, which is it's about looking at how do we get systematic uptake of best practices. Okay, so that's what we're looking at here, and recognizing that change is hard. So we need a systematic approach to achieve systematic uptake of any kind of change. But there's a broad range of research activities that fall under what we would describe, or at least what I would describe as implementation research, in order to achieve that end goal of improving quality of care or implementing best practices more reliably. So that could be knowledge synthesis, so like a systematic review of different things that people have done, different implementation strategies to understand how well they have worked in the wild. Or one could look at different instances of failures. There's a whole bunch of literature in the implementation research field that understands or tries to understand different barriers and facilitators to making change happen. And on it goes. I'm going to talk especially about evaluations of implementation strategies, but that upstream stuff of figuring out what the strategy should be is really, really important. So I'm going to talk about that first. Before we get there, this is basically the take-home slide. So if you were ignoring me up until this moment and you plan to go back to your emails afterwards, I'd like you to just bear with me and pay attention for the next 10 seconds or so while I walk you through this slide. And in fact, I think it's so important that I'm going to come back to it again a few times. So if we're going to do some implementation science research, I pose to you that my friend Simon French came up with the most straightforward approach to think through how you might do that. And that is for you to systematically answer the 4 questions that are up on your slide. And I'm going to actually talk to you about how you might think those things through, even without extreme sort of background in implementation science, okay? So the key questions to ask, as you see on this on the slide, are who needs to do what differently? And I want you to think about that. I'm going to show you that we need to think about that in like excruciating detail if we're going to get this right. So for instance, if we want families that look after a child who lives with complex illness to use an app, we need to think about what are the barriers and facilitators to them doing that. And before we get there, we want to think about the details like, do we want them to use that app on their computer or on their iPhone? When do we want them to use that app? Who exactly did we want to use that app? Is the brother or the mom or the dad or both? How often do we want them to use that app? Is it in the evening? Does it happen right after clinic or before clinic? Is it associated with clinic at all? To the extent that we can think through the actions we're asking of people in excruciating detail, we'll be more likely to come up with a successful strategy. And that's because if we can define who needs to do what differently in detail, then we can answer properly the second question, which is, well, why aren't they doing those things reliably already? And as you'll see, there's some structured ways that we can go about thinking through how to answer that question. It's not just, sitting around a table and, guessing. And then once we know why they're not doing that reliably already, we can systematically map the answers to that to some known strategies that might address those barriers that we identified. So that's part 3. And then part 4, of course, because I'm a researcher, you'll want to evaluate whether what you tried to do worked. And I'm sure you'll want to do that because you don't want to waste your time and you want to keep doing better and better as you go. So as I said, step 1 is so crucial to define in excruciating detail who needs to do what differently. And this doesn't sound scientific, I know. You can do this on a piece of paper, on a napkin, while sipping a coffee. However, there is a structure that might help, published by my friend Justin Perceau. I put the little sort of screenshot of the publication up there. And this is in the middle of the slide, a screenshot from inside the publication that suggests that you want to think about not just what is the action that we want them to do, but who is it? Who's the actor? What's the context? Where are they when we expect them to do this? Who are they doing it for? That's the target. And at what time or how often or how long will it take? These are the things to think through when we want to answer the question, who needs to do what differently? So the next thing that I want to just introduce you to is the concept of how we would go about answering, why aren't they doing that already? And indeed, why aren't they doing that reliably? And I think this raises questions that we all sort of recognize about how hard it is to change. So you see the comic at the left side of your screen there. It says, what if we don't change at all and something magical just happens? We all know that change is difficult. One of the reasons change is difficult sometimes is that sometimes you work within a context, such as an organization, that doesn't have a culture that's very, amenable to change. And so we have to think systematically about, for instance, organizational culture. If it's within an organization, maybe it's a family that we're looking to make change in. And so it's the family sort of dynamics that we'd have to think about in that scenario. Either way, what we want to do is not just pretend that there's zero knowledge out there about these issues of, barriers to change, but that in fact, people have been thinking about how to engage people in making change for 150 years. This is what psychologists do, for instance. And in fact, if we can leverage the theories that they've come up with, that can put us a few steps forward rather than pretend we have to reinvent the wheel every time. So that's the purpose of putting up that image on the right there, saying there's nothing so practical as a good theory. I know, many people get a little bit discouraged when a researcher starts talking about using theory, but I think I'd like to suggest to you that there are practical ways to use theory that need not feel intimidating. In fact, anytime you try to implement something, you implicitly have a theory about how and why it's going to work or not. The translation from that implicit in the back of your mind theory that is getting you to do this thing in the first place to, writing it down so you can share it with others about why you think something will work, that's going from implicit theory to program theory. And so that's doable. You can all do that. And in fact, to the extent that you have a good hypothesis, that's a theory about why this all will work. If you can build on something that already exists out there, you're probably going to be a few steps ahead. And I just wanted to introduce in the next slides about some things that you might be able to find useful in terms of building off of. So there is this book that you see on the right of your screen called The Behavior Change Wheel. And I think this is pretty interesting because it's an introduction for people like me that aren't psychologists. I'm just a simple family doc, remember? About how you can design interventions that might change behavior. And if we take it back 2 steps, ultimately implementation science, at least from my perspective, starts with thinking about whose behavior are you trying to change in what context to achieve, your desired outcome. That was question 1, basically, remember? So this is a wonderful book that you can Google and walks through for the non-expert how you can think that through. And it leverages actually a great deal of theory and makes it sort of not intimidating and very approachable for the non-theoretician, for the non-scientist even. For scientists, we went about making a guide for doing this. And you see that in the middle of the screen for unpacking what are the barriers and facilitators to making change to behavior. And the main thing I just want to highlight from that is that often there are more things to consider than we usually do. So for instance, this theoretical domains framework lists a whole bunch of categories that if you didn't have them on a list in front of you, you may not have thought of when you're building, your program theory, as it were, or your implicit hypotheses about why you think your strategy will or won't work in a given context. One that often we forget to think about, if not prompted by something like this, is emotion. If you think about it, so much of human behavior is dictated by emotion. You know that as parents, you know that as children. We were all children once and we still are to our parents, and many of us in the crowd probably have children. And so much of human behavior is dictated by emotion. And if we don't think about that when we're trying to change our patients or the clinicians' behaviors that look after those patients, we're going to miss a whole category of things we might need to do. I'm not going to spend time on this slide. Simply, it's there to show you that there are maps that can take you from emotion to things that are in the toolbox to address emotion, or if not emotion, then skills, or if not skills, then knowledge, and so on. But I do want to emphasize that too often we think that the rate limiting step for implementing our intervention is that they just don't know about it, that it's awareness and knowledge. And in fact, there's so much more to changing behavior than simple awareness or knowledge. Again, I'm not going to spend much time on this slide, but simply to show you that there's actually a website and app out there that, if you wanted, would help you map from what you think are the key determinants or barriers of the change that you're hoping for the person to make, to the things you can do to encourage that, address that underlying barrier or facilitator. So that's kind of cool. Like, psychologists have done all this work for us. They've created a map and it's out there now for us to navigate. Again, this is a complicated slide, but I have it here just to sort of highlight one of the ways of thinking about question 3. So question 3, if you recall, was, once we've thought through what are the reasons the person's doing that desired behavior reliably, question 3 was, what can we do about that? What feasible interventions or components of interventions might address those barriers and facilitators that we identified. So one of the reasons that I had this slide up is it's sort of to highlight that sometimes we come up with a brilliant idea, like, I don't know, a patient navigator program. And we do this sort of thing for complex patients, and that's wonderful. But we fail to say in detail what components of the patient navigator program are actually going to address which barriers or facilitators, and how are they going to do that? And to the extent that we can map that out, as we did in this diagram here, and you need not do it in using this exact format or in this much detail, but the more detail you can map that out, the better you can identify either areas where you actually forgot to think something through, or areas where you actually have to buff up the program in some way, shape, or form, or perhaps areas where you really want to focus on evaluation because that's the spot where you're spending most of your money, for instance. And I think what often happens when we're trying to implement a strategy is we kind of think about it as a really high level. Well, we'll hire a patient navigator, and we don't think about the components. And so one of the, I guess, take-home points for you is that implementation science is about, advancing the methods, in my mind, of how we think through the itty-bitty steps so that we can learn as we go, so that we don't have a million patient navigator programs that are all doing something kind of different, and we try to learn from them all. We're not exactly sure what they all did. Now, when you do want to figure out if it's working, if you're an implementation scientist, the first place you start isn't with the clinical outcome, but it's with more upstream, the implementation outcome. What I mean by that are there's these famous 8 measures by Enola Proctor, and they're listed here. So they're items about how well the strategy actually led to the immediate changes that you hoped for them to do. So, if we were trying to get a family to use an app, how well was that accepted? How properly did they adopt it? Did it fit the actual problem that the family was having? Was it implemented in the way that we would have hoped? So that's what sort of fidelity means. Did it get to all the families we would have hoped to, and so on. So you can see how that's sort of different than answering the question of, well, did it actually change their clinical outcome? Because remember, we're interested in implementation once we already know what the right things to do are, and we've realized that it's hard to get people to do that right thing all the time. So just to hit that point home a little bit, the time when we want to do an implementation research trial is not early on. So on this slide, again, I'm sorry, it's complicated, but on this slide early on at the left, step 1, you have a systematic review. You ask yourself, hey, do we already have systematic review, amazing evidence to show that there's a clinical intervention to address a clinical problem? And if the answer is yes, great. We know what the right thing to do is. Now you ask the next question, well, is that thing reliably, routinely implemented in practice? And when you say no, that's the time to think through the implementation strategy. And if you start to think that through, you want to look up in the literature, hey, did somebody already come up with the right way to get that implemented reliably? And when the answer then is no, that's the time to do these prior steps that we've walked through. So that's where this kind of fits. And if you find yourself in that red circle there with your work, it turns out there's not an app for that. There's a guide for that. So if you find yourself interested in doing an implementation trial, we recently published a guide about how to do that, and you can find that in BMJ if it interests you. So just wanted to highlight that there, and it walks through in detail some of the things that I highlighted here, but more specific for if you're running a randomized trial. I'm going to skip this slide because it's only relevant if you were going to do a trial, but I'm happy to come back to it during questions. I do want to emphasize this one here, though, just to say that implementation trials should feature what we call process evaluations. And I think that's really, really crucial because just thinking back to that patient navigator example, things can sometimes be a little bit like a black box. You know, in a trial, often it's described, well, we did patient navigators for these patients, we didn't for those patients, and the patient navigator group more reliably did the desired clinical action. Fantastic. But then, you know, we have all sorts of questions remaining, like how exactly did the patient navigator work? And was it implemented reliably for all the patients and families? Or, you know, were there some people for whom it worked better or worse, or needed to be adapted? And only if we unpack the answers to those questions would we be in a position to go from research phase to operations phase. What I mean by that is actually the goal of every implementation trial is to figure out how to inform, you know, normalized, routinized practice, that is practice policy. And if we're going to do that, a trial, it's just a boring set of numbers is usually not enough. We actually need the story as well about how to make it happen in new contexts. And then I want to make one final point. I think I'm okay for time. I'm going to finish up shortly. And that is to emphasize that implementation science increasingly is seen as crucial for ensuring health equity. And I'm going to try to make that point using, once again, a complicated figure, which I hope will become less complicated as I talk you through it. So here we go. On the slide, you see a gray bell curve. That's the one I want you to focus on first. And so in that gray bell curve, we see a bunch of bars, and we see some blue bars way off on the side. Those are the folks, let's call them family docs, who are not performing very well. Ideally, all the patients cared for those family docs, we really want to see improvement for. And, you know, it's not fair, that is to say, it's inequitable that patients cared for by those family docs are getting worse care just by the happenstance of who their family doc is. So a good implementation science initiative targets those family docs in particular. But what if all the family docs, like that is to say the middle of the bell curve, is also doing substandard care? Well, then ideally we want to shift the whole curve over towards the right where better care is happening. So a good implementation science initiative, a good strategy, not only tightens the curve, that is, pulls those people at the bottom part of the performance group way over, but actually, you know, so tightens the curve, but also shifts the whole curve over. And in doing so, we actually get more equitable, positive health outcomes. So I hope that makes some sense numerically. The other way to think about things, I think, is if we go back to question one, you know, whose behavior are we trying to change? Perhaps it's the clinicians down there in the bottom area, those blue bars, whose behavior we most want to change and who we can target with our strategy. So I told you I'd come back to these 4 questions, and then I'm going to wrap up. They are, who needs to do what differently? And I'd like you to think about defining those in excruciating detail. And you could use the sort of structure that I offered you earlier on, or another one. But the more detailed that you think about this, the more likely the rest of the steps are going to be successful. Question 2 is, why aren't they doing that reliably? Well, once again, there's frameworks to help you think through the range of barriers and facilitators that are out there. You don't want to miss things like emotion, for instance. Then you want to think, okay, now that I know that, what are the feasible options that might help address those issues I identified? And actually, there's maps out there on the internet that helps you go from stage 2 to stage 3, if you're interested in that. And then stage 4 is, how will you know that your plan is working? And if you're interested in a trial, well, there's a guide for that. But certainly along the way, really want to encourage you to think about equity. And I think that's where I wanted to land. I had this fancy animation there, but I'll stop screen sharing and go back to my video. Hey, look at that. I'm exactly on time.
Perfect. So thanks, Noah. Always really informative presentations and ways of thinking about things. Also wanted to put a plug that there is a workshop that we ran last month with the Center for Implementation that goes through some of these things in a bit more a different way as well. So if you want that video, hopefully you have it already, or contact Pierre. So opening up for questions, if anybody else wants to get us started. Dan.
Yeah. Well, first of all, huge thanks, Noah. I didn't know if in your dream job when you was a young person you wanted to be an influencer, but you did a great job here in that realm. So, a question I have is, in neurodevelopmental disabilities, we've come, the issue of awareness is really big. So each disability has programs for developing awareness. There's particularly thorny issues, like with fetal alcohol spectrum disorder, where it's recognized that, hey, all mums have to do is not drink, and then there wouldn't be any FASD. And the comment I always hear is that, well, they did that for smoking, and they did it for seatbelts. So I just love to hear your thoughts on those examples relative to more thorny examples, and what way forward might you suggest?
Yeah, so I think the seatbelts were not as simple as you describe. I think, yeah, even once laws were in place, I think it took perhaps a decade for it to become quite normalized. And prior to laws being in place, it wasn't a norm at all, right? Even though the evidence was there. So in that sense, maybe it's a great example. And I think it's a neat example because, asking people to change their behavior is probably it's often influenced by pure norms, and we see that for sure, right? Like, if your best buddy, buckles up beside you, you're probably just going to do it, even if you never did it before. When we think about fetal alcohol syndrome, I think it's quite interesting as well. So I don't think that awareness that alcohol is a problem during pregnancy is a major limitation anymore. I don't think. I think most people know that. I hope, I would imagine. So if that's true, then there must be other barriers that get in the way of the decisions that people are making. And, I think in that respect, the framework that I tried to offer, and my goal here today was to make it feel like some of the stuff we do in implementation science is things that any of you can incorporate too. And I feel like those 4 questions apply for these examples, actually.
Yeah, great. Thanks a lot.
Great. There's a hand up from Michelle.
Hi. Just wanted to thank Dr. Ivers. That was a really great presentation. I am new to Child Bright. I just joined the Citizen Engagement Committee, and I'm a parent and I have a daughter with complex medical needs. And so my question to you is, are you seeing, I really loved your point about mapping out those excruciating details, because I do find like we do have a coordinator for complex care, but I'm always saying, you know, you're seeing this much of our life because it's only within one hospital. We have 3 hospitals, there's school, and there's everything else. And I actually find sometimes it's harder because I have to keep track of what's in scope of the coordinator and what's out of scope because I'm managing the entire thing. So my question to you is, are you seeing that there are projects that involve family partners in mapping out some of these details that need to be considered?
Oh, what an awesome question. Yes, we're doing that increasingly. Absolutely. I must say my work focuses on trying to change behaviors of clinicians more so than behaviors of patients. But so I'll use that as an example here. So frequently, you know, people writing guidelines for, I don't know, kidney disease come to me and say, you know, Noah, why don't family docs just do so-and-so more often, you know, for their patients? And then, you know, the half hour later, I get an email complaining to me from some specialist about why don't family docs just do such and such more often for, you know, liver. And then the next half hour, I get and on and on and on it goes. And that example you just gave about how, you know, as a clinician for you and a complex patient, I only see this one spickle. It's kind of similar to how specialists kind of view my world as being a family doc. You know, and so when we're trying to make change in the family docs complex world, we have to get in there and kind of like see what it's really like for them and see why these things we hope they would do are not being prioritized compared to other things. And there are structured ways we can go about thinking that through. And so likewise with patients, I think we have to get in there. You know, we need boots in the ground, virtually, basically, and really get a sense of what's getting in the way and what we can do to alleviate that.
Great. Did you have any follow-up to that, Michelle? Or?
Yeah, no, that's great. I think even not only for the family's behavior, but also clinicians, I think for them to, because sometimes we get recommendations and they'll say, just look at this. And then within the recommendation, there's like 35 links. And then it's not even possible to even go, well, I'd be here all day. I'd have to just do it 12 hours a day. So I think it applies to both clinicians and to families to really, as you say, iron out those very minute details to say, you know, what is the information we want to convey? What are the 3 most the key things that are going to really move the needle on something?
Totally agree.
So I noticed there's a couple questions in the chat, but also know that we might want to have a couple minutes to break. So I was just going to check. Joanne, did you want to ask that question live, or shall I read that out?
Oh, I guess I can read it out. Thank you. Risk and uncertainty are increased conditions in managing neurodevelopmental disabilities. The complex questions, the hard questions are fundamental as per that drawing you put up. How can implementation science help recruit and support clinicians to optimize best practices with this population?
So if I'm understanding the question properly, it's that the clinicians that are in theory sort of meant to implement best practices in these populations, we're struggling to engage them. Is that the crux of it?
Well, the clinicians are just by definition working with NDD population being put between sort of a wall and a hard place. Lack of time, lack of awareness, the speed that science is going at, rare disorders, all that stuff, and that Michelle was talking about all that too, how the parents are coordinating. is there a way that implementation science can be referred to when a parent is trying to get the clinician's attention about something they're very well versed in because they've done their research and can convey that given the time limitations a clinician has?
Yeah, okay, I'll do my best to answer this. So
Thank you.
I think there are some folks working in implementation science in the realm of how do I phrase this? Sort of how do we help patients productively prepare for a doctor visit, or a visit with other health professional, and that preparation might be sort of a function of like, pre-sending information to that clinician, or it might be a function of, prioritizing for the clinician what the questions are, what the references are, this sort of thing. I think the other sort of realm where there's a whole bunch of literature in implementation science is how do we implement shared decision making, and I think that sort of applies here as well. And actually, there's systematic reviews about best practices about that as well. So I think this is an area of active interest in the field for sure. I don't have a specific answer other than say there's lots of work in that space.
Okay, thank you. Yeah, it was more about for the clinicians because they're short on time. They may lack expertise. They may not have the time to consult with journals, especially in rare disease, it's important. And so, yeah, even if patients go prepared with a list, and sometimes they have a lot of information.
I'm sure
It's I don't know if it's a communication thing or it's getting over the barriers, but okay, thank you.
Right, so thank you. I'm going to draw this part to an end. Noah, you will see there's a couple questions in the chat, so if you don't mind answering them in there, that particularly the one around the COM-B model, so we can make sure everybody gets a couple-minute break. But again, just wanted to say thank you for your presentation. It sounds like everybody really valued the information here, so thank you.